So, good morning, everyone. So, today we are going to discuss some cases, some endocrine emergency cases which we have seen over a period of last few years. There is a recency bias, so there will be a lot of cases which are relatively recent. And then, at some point I realized that, probably this was also interesting. So, maybe I added some other cases more as a, short of a one-line slide or something, right? Okay, let's start with a case. So, these are all, cases where there was perhaps a different initial assessment, and then it turned out to be something which was, probably different from what I thought. But all of them have a very good outcome. That in the end, that's what the story really ends with. So, important perspective we all need to understand, and this is something which is important for medical science, is that the eyes does not see what the mind does not know. This we have been all taught, for a long time. And I think in one pursuit of excellence in medical specialties, non-surgical medical specialties, is to really know and see cases which you do not think existed, right? Because if you don't know such a thing exists, sometimes, or if we are perhaps not updated with those things, perhaps you don't make that diagnosis, and that is what often leads to problems in terms of outcome, right? So, it's always that one little knack, one little magic bullet, which often brings out some good outcome. So, the first case, and we have Deepak Patel sir here, and this was very interesting because this is the patient very recent which sir had admitted. So, this is a 67-year-old male patient. Now, the story is the patient was from Mumbai, nothing to do with us, right? Patient went to a local hospital in Mumbai with fever and altered sensorium, okay, and was initially diagnosed as cerebral malaria, turned out to be, which was fair. But the sensorium progressively worsened, okay, and hence was neuroimaging was done because, cerebral malaria not improving, right? What interestingly it showed was a large pituitary mass with a bleed, which is a pituitary apoplexy, right? So, again, started with something, turned out to be completely different, right? So, the patient was admitted in a, if you see in Mumbai structure, the patient was admitted in a local nursing home, with perhaps 30-40 bed. They said this is beyond our management, so the patient was referred to Fortis Mulund, right? And he was taken to the emergency there, and he was prepped for emergency surgery, okay? But turns out, patient said that, patient's relative said, hold on, we want a second opinion, right? They contacted somebody, Dr. Deepak sir's fame preceded Gujarat boundaries, and the patient really came to us. So, overnight the patient was shifted to Zydus Hospital, Ahmedabad. Right now, at this point, the patient had pituitary apoplexy, pan-hypopit, he had diabetes and complicated malaria. So, this was the initial assessment. There was a non-functional adenoma with a unilateral stable loss of vision and unilateral third nerve palsy. We have seen a lot of these, we have seen a lot of third nerve palsies also. You have the extension into the cavernous sinus. So, we decided to treat the patient conservatively, right? This is an important kind of message will kind of come out in this. So, the thing about sorry, pituitary apoplexies are actually more common, okay, and overall the outcome was obviously good. The patient, after correction of hypopituitarism and treatment of the malaria, the consciousness and neurological symptom improved. The patient was discharged without a pituitary surgery with a good long-term outcome, and the idea was that we'll see how the neurological symptoms improve. And the last follow-up, which was just a few days back, the patient is doing relatively well. Now, to understand apoplexy is God's own pituitary surgery. Okay, this is when the thing about pituitary gland is that it is designed to have a limited blood supply because it is a limited, it's a small organ just like any other endocrine organ of the body. But when it grows in size, it takes up blood supply from the inferior hypophyseal artery as well, and this is that is not designed to really sustain a large organ, right? So, often when it goes beyond its boundaries, often it starts bleeding, right? And this is the same thing you see in Sheehan syndrome. We've all heard about Sheehan's. We've seen a lot of cases of Sheehan syndrome. So, the blood supply to the pituitary is not able to match up with the requirement. And beyond that, often there are triggers. So, sometimes in this case, clearly there was a cerebral malaria which triggered. So, the blood supply requirement was even higher, but did not match up, and the patient had started having a bleed, right? So, it's God's own pituitary surgery. We have seen a lot of cases with an empty cellar who come with pan-hypopituitarism. We have seen so many cases, right, who come with adrenal insufficiency, pan-hypopituitarism. Deepak sir or no neurosurgeon had operated. It was God who had operated the patient, right? You have a large sella, right? Where the large sella there was a bleed, and then the bleed eventually the pituitary gland got involuted, right? So that is what typically happens, right? So it's like the surgery being done by God himself. But the interesting thing is that if you see now there are well-written guidelines on apoplexy, and the apoplexy guidelines are very clear. The first line management is basically hemodynamic stability and glucocorticoids. That is the quintessential management of apoplexy, right? Because in apoplexy, initially, the causes of death are A, adrenal insufficiency or raised intracranial pressure. And both these conditions can lead to further worsening. Of course, what you have to monitor are two things. One is the vision involvement, and the second is the consciousness. And if you have a reduced visual acuity or worsening of the visual fields, in such cases, the patient should be admitted to the ICU and should consider surgery. Otherwise, the patient can be monitored conservatively. When you have a stable loss of vision, they'll have loss of vision, but if it's a stable loss of vision, then the patient can be managed conservatively. So the primary management in most of these cases is medical. And sir also agrees to this. We have seen a lot of cases with sir over a period of time. There is no role of immediate surgery. That is one very important lesson, right? In fact, if you see the guidelines, if you see a lot of papers on this, the outcome is worse in patients who go for immediate surgery, right? Outcome is better where you have either early surgery within the first 3 days or perhaps late surgery within the first 7 days. So the surgery has to be done either early or late, but there are pros and cons for that. But end of the day, it's not an emergency surgery. It's not something you prep the patient for surgery and take him for surgery overnight, right? That is what should not be done, right? In fact, now there are outcomes where it is shown that surgery may not be required in all cases at all, right? A lot of these cases you do not require surgical intervention. The choice between surgery and conservative depends on individual patient factors, severity of symptoms, presence of complications, and so on and so forth, right? But having said that, the surgery is either early, even if you consider surgery, early surgery is as early as 3 days and within the first 3 days, and late surgery is within first 7 days, right? So these are the two things. Now there are papers which have shown that whether it's early surgery or late surgery, right, the outcome is often very similar, right? So in terms of all the outcomes. So again, the idea is to be prudent and not to rush the patient to surgery, but to consider more pragmatic aspects of management, right? So this is the first case. Now let me tell you a second case which is very interesting, right? In a similar light and in a similar, let me say, direction. So this is a 57-year-old male patient presented with history of fever, vomiting, loss of consciousness, etc. An evaluation in the emergency was suggested. So everything was done. The main issue was hyponatremia, right? Persistent. We have seen so many cases of hyponatremia. Hyponatremia is something we see day in, day out, every day. The sodium at that point of time was 129, and the prior sodium, you can see in there was some general health checkup done where it was 135. So the sodium was normal previously, maybe 1 month back, right? So whatever has happened is that 135 has gone to 129 or whatever value that was within a period of a month, which we know, right? Now, patient had a history of similar illness in the past, and hyponatremia was repeatedly recognized and then corrected, right? Now, the patient's daughter was a medical student, a smart one. She noticed that whenever my father has fever, sodium ochu thai jai chhe, right? Sodium comes down whenever he has fever, right? Every time he has fever, sodium tends to come down. Of course, also very interesting, patient has history of hypothyroidism for which he is taking levothyroxine, right? 50 microgram. So we did the obvious, right? Send a serum osmolarity, serum sodium, urine osmolarity, urine sodium, right? These are 4 things we always send in all patients, which we do as a part of protocol. But a lot of the times, we even, do not see the reports and interpret it, right? Because by that time, you would already have some sort of, synergy to that. Again, new guidelines, if you're seen, there are new guidelines on management of hyponatremia where they say, the thing about hyponatremia is, there are 2 things. One is how fast the hyponatremia developed, which is very important, right? So a patient with a sodium of 129 could be sitting amongst us right now, right, without anything. A patient with a sodium of 130 could be right now in the emergency, because it's the acuteness with which the sodium drops. The body does not have the time to compensate for that. That is what leads to the symptoms, and rather than the absolute value itself, right? Perhaps a 120 sodium would not be sitting amongst us, right? So the value also matters, but the point is what really matters is the acuteness of the symptom. And when you have an acute hyponatremia, when you have documented acute hyponatremia, now the new guidelines and their new treatment protocol says that we all, we are very conservative. We give, 3%, 30 ml per hour, 40 ml per hour. No. When you have an acute hyponatremia, you should consider giving a bolus of 3%. and try to raise the sodium by 5 milliequivalents within the first hour, right? And that leads to better outcome compared to other things, right? Important thing now, then, once the patient gained consciousness, right, the doctor of course knew this, did not know what surgery was done, but the important history was very obvious here. The patient had a history of pituitary surgery, right, for non-functioning pituitary adenoma, very similar. So it is like the earlier case, but in this case it was operated, and the patient basically had this. So these were the lab reports. You can see, the patient was euvolumic, so you can have sodium 129 osmolarity, which is hypoosmolar hyponatremia. A very important point I really like to make here, right? And this I have been saying for a long time, and in retrospect, it comes out to be true. Perhaps the most important and unrecognized cause of euvolumic hyponatremia. We all label this patient as SIDH. Lot of times, you have seen so many patients being labeled as SIDH. The thing you have to rule out, remember, SIDH is a diagnosis of exclusion. And there are two conditions we should rule out in such cases. One is adrenal insufficiency, and second is your hypothyroidism. Now, hypothyroidism producing hyponatremia, primary hypothyroidism producing hyponatremia is very rare because the hypothyroid has to be very severe, right? But a central hypothyroidism producing hyponatremia is much more common, right? Central hypothyroidism is when you have low T3, low T4 with a normal or low TSH. But adrenal insufficiency producing hyponatremia is in Indian setup. You will not see this in West very commonly, because they are very acutely aware and keep monitoring sodium in a patient giving steroid for a long time. In India, we often don't do that. A lot of these patients have hyponatremia because of adrenal insufficiency. And remember, the thing about if the HP axis is not fully functional, whenever there is an increased physiological stress, could be fever, could be patient ran a marathon, right? Could be anything, right? Any physiological, could be surgery, right? A physiological stress increases the workload of the pituitary gland, which it's not able to match up, and you have hyponatremia, right? So a very important cause of hyponatremia. Remember, a lot of our patients are on alternative medications, which, trust me, I'm telling you this, right? When a patient comes to you saying that મને joint pain હતું, મને શરદી ખાંસી હતી, મને એલર્જી હતી, મને સ્કિનમાં લીઝન હતું જે મને આયુર્વેદિક દવા આપી અને સારું થઈ ગયું, it is dexamethasone unless proved otherwise, right? It is for sure, right? And patients take this for a long time, and patients have adrenal insufficiency. We have seen so many cases over the years, right? So whenever you have hyponatremia, it is very important that a treatable cause of hyponatremia should be sought, right? Secondary or tertiary adrenal insufficiency is a very important cause of hyponatremia, right? The difference you have to remember, and this is a common rookie error often made, primary adrenal insufficiency, Addison's disease, where you have the adrenal gland involved, you have hyperkalemia with hyponatremia. But when you have central adrenal insufficiency, when you have hypopituitarism or hypothalamic involvement, you have low sodium with often normal potassium. Sometimes even the potassium can be low, because if the patient is actively on steroids, had been taking steroids recently, the potassium can even be low, right? So low sodium with a normal potassium or a low potassium, consider secondary or tertiary adrenal insufficiency. Why adrenal insufficiency develops in these cases is, remember, always remember this, sodium, it's not a disease of salt, it's a disease of water, right? And the key hormone here is antidiuretic hormone, right? So ADH and CRH both, right, come from hypothalamus. They stimulate ACTH, and they stimulate, which stimulates cortisol. Now there is a negative feedback. When the cortisol is high, it suppresses ACTH, ADH and CRH. It also suppresses ADH, right? So what happens is, if the cortisol is low, right, that feedback is gone, so ADH is high, right? Now we call it SIADH, right, inappropriate ADH. Adrenal insufficiency is quintessential SIADH, right? Because of the hypocortisolism, the patient has high ADH. Having said that, we also need to understand that adrenal insufficiency, no matter how much we try and understand and how much we try and dissect, there are a lot of times we cannot say for sure whether this patient has adrenal insufficiency or not, and whenever in doubt, treat it like adrenal insufficiency. I'll tell you why. Because remember, like I said, in you and me, if you do cortisol level, and if it comes to be value of 6, it is, I would say, fine. But in a patient with a physiological stress, that value is low, right? You would have seen in ICUs patients with cortisol of 12 and 13, where we have put the patient as an adrenal insufficiency, because in an ICU sick patient, that value of 12 is not enough, right? So in endocrine, you have to, whatever it is, you have to interpret in the context of what the other clinical situation is, right? That is very important to understand and realize. So we did a ACTH stimulation test in this patient, right? And we use actin prolongation. Now we have, of course, synactin also available in India, right? And when post stimulation, the cortisol value was less than 18, which kind of proved that the patient has adrenal insufficiency. And another test, this is, remember, a lot of people have started using this in our hospital, right? Our gharnu invention che. DHES, is something which we use. We are not published so much about it, but this is something which has come from the institute where I worked and carried on forward here. DHES is a very useful test to assess the adrenal axis for the last 2-3 weeks. It kind of removes the problem which we have with cortisol. Problem with cortisol is it has a short half-life. The second is sometimes if the patient is already on steroids, sometimes that can be cross-assayed in your assay, right? So DHES solves this problem, and we have a on a endocrinology India website, you can see we have given a protocol which includes DHES in terms of adrenal insufficiency assessment, right? So this patient was started on hydrocortisone followed by oral Hyzon, right? And the patient improved. Another important message you all must remember that when you have a patient with pituitary surgery, remember post pituitary surgery, right? Some of the patients, initially all of the patients should be treated like pan-hypopit unless proved otherwise, but over a period of time, some of them have improvement in the pituitary function where you can remove the drugs. In some of the cases, the pituitary hypopituitarism persists. Some of the cases, they have partial forms of hypopituitarism, where in routine day-to-day cases, they are alive and they are fine, but in cases of physiological stress, they'll require steroids to be replaced, right? So that's an important message we need to understand. The third case, and this is very recent and very interesting. So this is a 25-year-old female patient, had seizures in the last trimester. This is scary, right? It's pure luck that the patient ended with us and patient ended up with a great outcome, which it could have gone badly in so many cases. She had seizures in her last trimester, close to term. This is anybody's nightmare, right? Glucose was 26. Right, at that point of time, started on glucose, dextrose, anti-epileptics, LSCS was done, close to term. Hypoglycemia post LSCS persisted. Right, patient was admitted, so the gynecologist put the patient to an ICU. The ICU guy said, "Amaru kam nathi, tame Zydus jata raho." Right, patient, the physician called me. Right, I was sitting in the OPD. I said, "Send straight away to the OPD." Right, patient, patient conscious oriented che. Amna jame dextrose aap piche. I fine. Right, patient was in Bhopal. The patient was sent here. Right, on evaluation in the OPD. Right. Patient had a glucose of 30, critical sample. So, an important thing for emergency care also, whenever you have a patient with hypoglycemia, you start the patient on dextrose, but take a critical sample. This will be a great help to us and to mankind in general, right? Take some extra samples, because the major issue in analyzing or in assessment of hypoglycemia is to have a sample which is there when the patient had hypoglycemia. Sometimes what happens is if you miss the critical sample, then we have to admit the patient for a lot of days and do something which is very painful, is to do what is known as a 72-hour fast test, where you have to induce a hypoglycemia to take that critical sample, which is sad, right? So whenever you have a patient with hypoglycemia, even if you know that this is probably drug induced, sulfonylurea induced or insulin induced, still take a critical sample, right? We can discard that sample later, right, and do nothing about it, but an extra sample in a lot of these cases can be useful, right? I remember there are cases, and I don't know if you were aware, there was a period of time not only in our hospital but across the state where patients had unexplained, if you remember, Dantara sir had a patient, right? Unexplained hypoglycemia which occurred to a lot of patients, unexplained. There was a patient from Shelby who post-operatively developed a severe hypoglycemia, almost died, and brought here, right? So a lot of us endocrinologists, we discussed, there were cases from Kutch, there are cases from Rajkot, there are cases from Surat, right? So it was pan-Gujarat, and there are no cases from outside, right? Similar. Our differential was that if it's cases coming from all these cases, and most of these patients had exposure to recent hospitalization, it has to be something drug-related, right? We came out with candidate drugs. Turned out there was one, I'll not name the company, there was a brand of pantoprazole, which was found to trigger autoimmunity, right? The entire batch, right? The company was notified and it was withdrawn. I think there was a small article in newspaper also regarding this, right? But this is what ultimately happened. At that time, we were very, our candidate was optineuron. It turned out to be, probably not true, but there was some pantoprazole brand which was causing this, right? So these things happen. This patient we admitted, we took the critical sample, started the patient on oral diazoxide and octreotide, right, with a glucagon, and this is what we started. The patient was admitted in 7A ICU. This was the critical sample results, right? So by that time we started the patient on treatment. The C peptide was 6, insulin was 68, beta hydroxybutyrate was low, so it was suppressed, and cortisol was 21. Again, we have a patient with hypoglycemia, always send cortisol also, because adrenal insufficiency is also cause of hypoglycemia. So interpretation is, this is what is known as insulin dependent hypoglycemia. So when you have glucose less than 55, C-peptide more than 0.6, any detectable, see, for the first line of defense of the body against hypoglycemia is to reduce the insulin level, right? And this, in such cases, so when you have C-peptide more than 6, insulin levels more than 3, pro-insulin we don't do, beta-hydroxybutyrate less than 2.7, this is what is known as insulin dependent hypoglycemia. Insulin dependent hypoglycemia, the next step is to hunt for an insulinoma. So we did a CT pancreatic protocol, did not show a lesion. At this point, when you have CT which is normal, there are 3 options you have. Either you go for USG, which has absolutely no role. Don't do USG, it's waste of money, right? Unless there is some other reason to do it. A non-contrast low resolution CT also has no role, remember, because a lot of the time it will not pick up the lesion. These are very small lesions. A dedicated CT pancreatic protocol has a role, but still misses 30% cases, right? So this is the initial imaging. So advanced imaging, you have 3 options. Either you do endoscopic ultrasound, and we have picked up cases using endosono, gallium 68 DOTA PET, but remember endosono is also operator dependent, right? It depends on the, like a lot of ultrasounds, right? So your gallium 68 DOTA PET and then gallium 68 exendin PET, we are lucky we have both these tracers available. The patient was very lucky because our own patient, right, the same day we had called that patient for an exendin scan. So I called Sunny Gandhi. I said, I have this patient, how soon we can do exendin? Tu kai na kar tu hamda mokli aap, right? Karke taru je ek patient che je aje આવ્યું છે and we have the tracer available. The same day we got the exendin scan done, for which patients even in Bangalore have to wait for 2-3 weeks, right? Because you have to order the tracer, right? Which was very lucky. So we did the exendin, and even more luckier was we localized the lesion immediately, right? So same day patient got admitted, diagnosis was made, insulin dependent hypoglycemia was recognized, exendin scan was done, and the lesion was localized, which is, I think, never happened in my career, right? But it's very rare to happen in anywhere in India. It's just pure sheer luck of the patient, right? We did, Dr. Mahesh Patel did robotic spleen preserving distal pancreatectomy the very next day, right? Which is also rare. If you're interested, Mahesh D. Patel has a YouTube channel where he actually put this video, and it's actually a work of art, right? So I think I saw this, it's beautiful, right? So this video is there, right, of this patient, this particular patient, where we did histopath confirmed the diagnosis, right? And luckily, again, very lucky for the patient, it was a low grade tumor without a metastasis. We have seen mets also. I'll show one case. Post-operatively, patient's blood sugar completely normal. We had tough time. Amit knows. We get so much dextrose and octreotide and everything before the surgery. Post-surgery, patient required nothing, right? Absolutely, perfectly normal, right? Patient currently perfectly fine. She's fine. Baby is fine, right? Not on any treatment, right? Perfectly fine at home. Okay. Another interesting, very similar, right, but a completely different etiology. This is a 25-year-old female, another young girl. I got a call from physician from Bhuj saying that she has recurrent hypoglycemia with 1 episode of seizure and recent history of severe headache, right? So patient was transferred to us with dextrose infusion, right? On seeing the patient, the history was patient had history of primary infertility, oligoamenorrhea, weight loss. This is typical history. He immediately sent the samples. The random sugar was 78, so we did not take a critical sample. This was a problem, right? So if the patient they had taken critical sample, it would have been good. But despite that, the random cortisol formalized the diagnosis. It was very low, 2.4. Free T4 was 0.6. TSH and other things were fine. You can see here, right? So what you can see, this is God being pituitary surgeon. Okay, there was an apoplexy perhaps in the distant past when she had probably time with the headache, right? And eventually the pituitary involuted and you have a partial empty sella, right? So this is what the patient had, right? All we did was make the diagnosis of pan-hypopituitarism, started the patient on, so again, hypoglycemia along with hyponatremia. Hypoglycemia is an important cause of adrenal insufficiency. We replace the hormones, replace glucocorticoids before giving. Always remember such cases, don't give thyroid first, right? Give adrenal replacement first, right? And so important cause of hypoglycemia. Now, interesting thing is, this also helped us with the patient's initial diagnosis, which was infertility, right? The patient was actually going, patient was going from pillar to post for the fertility part. Now you had the clear region for the fertility, right? So we talked to the fertility specialist. We did the routine protocol with HCG and HMG and all that, right? Very recently, March, the patient delivered a baby, right? So I think that hypoglycemia made the diagnosis for the patient, right? Which is interesting. Okay, so let me skip this one. Let me go to the sixth case and a few other cases. Now, this is again a little bit traumatic experience as well. So, 68-year-old female, she's an anesthetic in one of the Zydus network hospitals, right? Doctor herself, elderly lady, presented with back pain and vertebral fracture. Okay, so she had history of fragility fracture also in the past, right? This was there, but no biochemical investigation was done, which is very strange. So patient went to a local orthopedic surgeon in that region and was started on teriparatide without biochemical evaluation. Now this is where the problem lies. Okay, so few weeks after the same, the patient started developing. Patient got worse, right? Whatever it was. We received the phone call from the said hospital regarding the patient. So he said, why don't you do a calcium and PTH? Now I said, history teriparatide was given. I said, was calcium done before that? No, right? So I said, so okay, send it, right? So calcium and PTH, we just asked that on phone. This was the report. 16 calcium, 1900 PTH, creatinine of 2. We said, Mukli Apo patient, right? The patient was sent, right? Started on IV fluid, calcitonin, denosumab. Now, two differentials here. Was it just teriparatide induced or patient actually had primary hyperpara and the teriparatide was given? That was the differential, right? So, calcium started coming down. We did the parathyroid scan. I said, once the calcium settles, there's a huge parathyroid adenoma, large. Right, Mahesh H. Patel operated this patient, and we gave the irradiation also to the bed. Turned out to be low-grade malignancy, right? But the point was that, and very important lesson here, we all need to understand, hypercalcemia is a big challenge, right? We see a lot of these cases, and in fact, if you see in terms of, common causes, hyperpara is still the most common cause of hypercalcemia, right? It is the most common cause of hypercalcemia, even in India. In India, unfortunately, the second cause is often iatrogenic, vitamin D toxicity. Now we see less cases, but there was a time where, so again, one thing I'll tell you, unless you have, don't give Roquetrol to elderly patients, right? Your Gemcals and Gemcal now they change the preparation, but a lot of these patients, remember Roquetrol is an active vitamin D. Unless you have chronic kidney disease or you have hypopara, give Roquetrol. Calcitriol, right? See, body has a very nice defense system against hypercalcemia. So what happens is, if your vitamin D level is 150 also, you may not develop hypercalcemia, because what the body does, it doesn't activate the vitamin D, right? Body much right? But Roquetrol or this calcitriol, what it does is, it bypasses the system and you have actual active vitamin D. So as soon as you give active vitamin D, and a lot of these patients are having baseline poor, calcium issues, suddenly the intestine starts absorbing calcium in plenty, right? And patient develops hypercalcemia, right? Beyond that, of course, somebody would have given teriparatide, somebody would have given vitamin D injections, right? Everything else, right? And patients come with hypercalcemia, right? Dr. Ambrish Mittal had written so many case reports, even ended up writing to the Ministry of Health saying that we should have some label on Roquetrol saying that it should be only prescribed by endocrinologists or nephrologists, right? That level, thankfully the company which makes Gemcal, I'm sorry to say the brand, right, actually changed the preparation and stopped adding, I think now the current one doesn't have calcitriol. There's a separate one which still gives calcitriol, but that's something which is very, very essential. We have to be very careful. Hypercalcemia malignancy, again, an important cause, right?
Lots of people are coming with calcitriol.
Yeah, should absolutely stop it immediately, right? So calcitriol, the indications for calcitriol are only twofold, right? You have a patient with hypoparathyroidism documented, right? Surgical or idiopathic, whatever. Or you have a patient with chronic kidney disease where you have the parathyroid, but it's not functioning. So pseudo hyperpara or secondary hyperpara, or these cases, right? These are the cases where limited group of patients where you give calcitriol, right? In other patients, let the body do its work. Give vitamin D, right? Bhale thodo slowly patient improves, no problem. But at least you will prevent an emergency, right? That's the problem, right? So never start. Even I have seen the other way also. Patients given denosumab landing up with hypocalcemia, very common, right? And then not being diagnosed for days. What is actually happening, right? But so whatever osteoporosis medications you're giving, a baseline biochemical assessment is a must, right? A calcium, PTH, vitamin D, ALP levels will not cost you more than 1,000, 2,000 rupees, right? It should be done in all patients before you give expensive osteoporosis medications, right? Medication is far more expensive than one line of treatment. And all hypercalcemic patients, right, you need to first assess and then treat, right? So assessment is most important. It's to establish the diagnosis which is important, right? Again, let me run through some other interesting cases. This was a patient which Tejas Parikh had, admitted. A young boy, with prior history of recurrent fracture with trivial trauma, presented to emergency with lower limb weakness. He had hypokalemia, metabolic acidosis, and normal anion gap, right? Now, very sad to say, a first year endocrinology resident would make this diagnosis. The patient was seen by a senior endocrinologist for many years, right? Saw the patient in 2 minutes, said this is RTA, right? Simple, right? This is a simple, it's like a MCQ type of questions for endocrinology entrance exams, right? Very classical, distal RTA, undiagnosed for a long time, right? All we required was giving bicarbonate, patient improved, right? Patient is doing very well right now. This patient, I just remembered, when I started putting hypokalemia in, this Dr. Hitesh Modi and me, my job here is just to make the diagnosis. I had done nothing for this paper. Everything was written by Hitesh Modi. So this was another patient with hypokalemic periodic paralysis, was suspected to be an intradural spinal tumor, turned out to be a primary aldosteronism, had a big adrenal mass, right? And ultimately, without any surgical intervention with potassium and aldactone, the patient improved, and then later on, patient went for the surgery. Right, the patient is currently doing fine. Right, not on any except for few anti-hypertensive. Patient is fine. This is another recent patient. This is the insulinoma gone bad. Right, so you had insulinoma with metastasis. Right, where the patient, in fact, everybody had lost hope. Right, me, oncologist, Naush, Sunny, patient herself, patient's relatives, everybody, right? Very stormy course, hypoglycemia was very difficult to correct. PRRT was given first time, first there was poor response, yet we pursued, right? The second and the third PRRT, patient is completely now in remission, right? Which is outstanding. In between, of course, she had, LRTI and the other things, but end of the day, right now doing very well. Trust me, we looked up to cases like this, right? The survival rate is very poor. For her to survive this long is also a miracle in itself. So I think sometimes, patients come with a lot of luck within them, right? Treatable causes of heart failure, right? We have seen a lot of cases of heart failure, and there's a dictum that what are the reversible causes of heart failure? Well, most of them are endocrine. You have pan-hypopituitarism. We have 4 patients over a period of time, including 2 Sheehan's patients. With Sir Kalpesh sir also, we had 1 patient, right? Vidya, right? So pan-hypopit, that's a Sheehan's. We have another 2 or 3 Sheehan's patients. All of them were having heart failure, was diagnosed to have hypopituitarism. Treated them, their ejection fraction is improved. Patient is not having heart failure anymore. That's simple as that. Hypokalemia, right? Hypoparathyroid surgery, post-parathyroid surgery, we have seen a lot of patients. 2 patients though I have seen recently. Thyrotoxicosis associated heart failure, of course, is very common, but important condition, again unrecognized, is Takotsubo's cardiomyopathy, right? Me with Dr. Sanjay Kalra, we have written extensive, we have a lot of papers on this, right? Takotsubo cardiomyopathy is also known as broken heart syndrome, where the patient typically presents with heart failure because of sympathetic thing, right? Everything points to heart failure, but when you do coronaries, right, they're completely clean, right? Important endocrine cause, this itself is an endocrine condition, but the important endocrine cause, 2 of them are very important. One is pheochromocytoma, and we had 2 patients where we diagnosed pheochromocytoma after Takotsubo, Bhavesh Roy's patients, and 1 patient who had Cushing syndrome, right? So Cushing syndrome is also an important cause of Takotsubo cardiomyopathy, right? So an important treatable cause of these conditions, right? So just to summarize, pituitary apoplexy, important cause. The primary management is endocrine. Remember, surgery is not, there's no urgency in surgery. Hypoglycemia, very important. Diabetic or not, right? Take a critical sample. That is very, very important. That will help us in a long way. And any patient with hyponatremia, any patient with hyponatremia in India, always consider adrenal insufficiency as an important cause, right? Because a lot of them actually have it, right? And this is very, very common, right? Hypercalcemia, again, still remember primary hyperpara is very common, but iatrogenic cause is also not uncommon, right? Hypokalemia, these are all endocrine causes, exogenous Cushing's, ACTH dependent Cushing's, primary aldo, these 3 are very important causes. Recently, another recent patient with hypokalemia, we already on antihypertensives, resistant hypertension, we directly went for CT, turned out to a young female with a large mass, right? So Raj is going to operate this patient next week. Yeah, so these are the outcomes, right? Important thing which I often believe is that, if you want to pursue one thing in life, let's pursue it for excellence, right? I think in any branch or any field or, any speciality that you deal with, I think at the end of the day, the only pursuit which is worth pursuing is excellence, right? If you are not that, then, try to be that. That's the only message, right? So this is our, we had published these two books. They're doing thankfully very well. One of them became, to our surprise, also Amazon bestseller, right? We had this notes in endocrinology. We are doing this for a long time. We had right now more than 10,000 readers on a regular basis. We had an app which we discontinued because of cost reasons, because Apple becomes more greedy over a period of time. You don't realize that. We all have iPhones, so we realize that, but that's the thing. We are coming up with this book very soon, 6 healthcare trends for the future. I think an important thing here is that a lot of healthcare is now changing, right? You would have seen a lot of my talks on AI, but it's not just AI, right? The entire system is now churning. I think there's a change which is happening in terms of healthcare. More and more, things are moving from surgical to minimally invasive techniques to non-invasive systems, right? A lot of things are moving towards a telemedicine, brick and click models, right? So healthcare is changing for the good, right? I think it will become more and more accessible. Not that doctors will become irrelevant. In fact, our relevance will be sharpened. That is, and for a hospital like us, we are actually going to benefit a lot. But I think so. We need to be aware of the trends, and we need to be flying with the trends rather than moving against it. Thank you.
I have a question.
Yes.